So there's plenty of questions that have come in through Slido, and I've been looking at those, and I've kind of pooled them. So I'm going to start off with some questions for the panel, and then we will open it one or two to the floor, because I know communications have been waiting patiently with a box to throw at people for questions. And so hopefully we'll have the opportunity to do that whilst ending at 5:30 for the next session. So thank you very much to the panel. It's been very interesting to hear from researchers and data provider perspectives, and the brilliant example of the trusted research environment, and plenty of advice given already through your presentations. We might hit on that again, Francis, as we go through. But even one of the pillars that, Sarah, you presented on through TATUS was looking at data quality and standards. And I think a lot of people have talked about the challenges of data quality and standards throughout. But as we are moving into that ambition of having a trusted research environment or an equivalent with underpinning legislation, can I just ask you as panelists from researchers' perspective, data providers' perspective, what will that mean immediately to you? What will change research and your data and the data standards once something like that is in place?
Just to say, I was on the work package on data quality and TDAS. So all of the member states that came together to look at data quality issues and what a data quality framework would look like, and what kind of dimensions you would look at. We're fortunate in Ireland in that HICWA has done quite a bit of work in this, and I know in the HRB we used their self-assessment tool to examine the data quality of our own systems and put in place measures to address that, and that's a kind of an ongoing process. So I think as it develops at a broader kind of European level, there will be further challenges, but I think the ultimate goal is obviously looking at the quality of the data, and that's where we all want to be, really.
Yes. Yeah, you can see the importance of it. And from a research perspective?
I mean, I think Ireland will be, in somewhat a unique place because, as I mentioned, in our hospital system, it's paper-based records at the moment, So unless we're going to be extracting data from that, certainly with the emergence of an electronic record, I'm sure there'll be opportunities to, look at the quality, the accuracy, the reliability, of data. I think there'll be some data sets which will be highly reliable, good quality. Some of the national data sets, in hospitalization to an extent, medication use to an extent. But the other clinical data sets that I would like to see, kind of evaluated in detail would be primary care data sets. So I think there's a body of work that needs to be done, and that will require stakeholder, engagement and involvement. But I mean, it's great to see that what's happening in Northern Ireland. I mean, it's fabulous. I have to say that. We just have to push on and try and get there.
Okay. Gráinne?
Yeah, no, I agree. And I think then in terms of if there's standardized approaches, then even just the external validity of the information that we have, we can be certain that differences or similarities we observe are because they're really the same, or they're really different, not because they're using different measurements.
Yeah. And Francis, can I ask you this question, if it's relevant? Like, you have a trusted research environment. We're thinking of it and putting that infrastructure in place for our technical solution. Should we be thinking about linking in with yours, looking up to see how they might work together, interoperability?
Yeah.
And if so, what would you advise at this early stage?
Yeah, that's a tricky question because so we adopted the Security Research Platform because it already existed in SEAL, and it was literally a TRE in a box to a certain extent. That's what it enabled to do. However, when we build out with our electronic care record and Encompass, which is our new system based on Epic, I would imagine that we will have the capability to build out on the platform, the Northern Ireland, the Health Innovation Platform, to create a different infrastructure to bolt your TRE onto. So your TRE sits as the interface between the back office system which manages your data. It's irrelevant where it's warehoused and how it's warehoused. Yeah. Your trusted research environment is just the mechanism by which you can be assured of a governance process and allow safe access to a restricted level of data pertinent to that application. So while I would say that what we did was, excuse me, the benefit of excuse me, the security research platform is that we were able to go from no remote access to full remote access within 9 months.
Yeah.
If you are building out your capability across the wider ecosystem, it's best just that you build that in terms of what you want to have on the front end. So I recently spoke to some colleagues in Tilda, and they're looking to try and put a TRE capability. Something like the security research platform works perfectly for that.
Okay.
You can do it in stages. You could put a TRE in place via SERP for a particular data set provisioning that you're comfortable doing now, or you could use something like the Tilda cohort as an exemplar for how you would do that, and then build out from there. So it depends on which model you wish to go for.
Okay, thank you.
I
Austin,
have
you
a
want to come in
question and
there?
a comment, and a question just for Francis. Do you, so is it possible to have multiple trusted, environments within the same
Of course.
country, and that's
Yeah, so across the UK, there are multiple trusted research environments. So we're at the stage now where we're looking at federated access. So how does an individual researcher make an application and also do a cohort identification and access data through multiple TREs from one point of application? So there is the capability to do that. We have ended up with TREs coming from different infrastructures. So you have the British Heart Foundation, they have their own TRE. Then you have TREs like Open Safely, and you have TREs that, like Q Research, that came from within universities. So you might have cohorts which exist from HEIs, but then you might also have your own HSE infrastructure TRE. The question is, how do you enable the value add of linking your population level data to cohort data through one TRE application? And that's what the HDR Innovation Gateway tried to do, and what the purpose of federation is. So being a late adapter can sometimes be a great benefit to this, because you can actually see your data ecosystem. So I suppose that what I would say is, if you have the opportunity to look and have a definitive list of your existing data infrastructure within the HSC, the cohorts that you want to bring on board, where do they currently sit, and how can you align their governance before you place a TRE under the front of them?
Okay, thank you.
just a comment. I was saying, you're asking about what should the Republic of Ireland do, and in terms of alignment. And I mean, if I was running this show, I'd be saying, well, I certainly look at Northern Ireland, and clearly you'll have to look at the
Wales.
your European best practice. But clearly they've done it in a kind of a relatively short time frame. And look at the time factor. They've a scalable, development. They've looked at the governance, the technical, the implementation. I mean, I think we should look at it, because we're on the same island. Certainly for all island research, it would be great to have the same type of infrastructural governance, access, trusted environments, and that would be a fabulous addition to the health system.
I'm not going to sit here and say that Northern Ireland is at the head of the curve, or is in any way a front leader in this. We have certainly learnt and taken great value from best practice in other places. We were the partnership through SEAL to enable us to do that in 9 months was exemplary, and it is credit to them to support us in doing that. The work that was already done through the Honest Broker Service and its head of service and his vision for what should happen to the Honest Broker Service, the fact that was already in place from 2014, and there was vision to have that in Northern Ireland, certainly was advantageous. I think I would look to some of your European partners and what they do in terms of infrastructure, cloud computing. The capability will outstrip your legislative and your regulatory practices. So you need to have your governance, your regulation in place, because technically it's all there. You just have to pick a package. But you need your regulations and your legislation in place and your governance systems in place before you do the front end.
Yeah. And then just picking up and moving on from that topic onto another one is, and Gráinne, you had mentioned it within your presentation, it's about when we look to the future and all the opportunities that, when infrastructure is in place and the legislation is in place for us, it's about big data capability and having the resources and the skill sets to be able to help us look at that research and to analyze it and look at it. So just to open that up to the floor to say, do we have solutions? What kind of roles? Do we need new roles to help us with this? And Francis, you probably have experience of the kind of roles, and what level of support is needed from health institutions to move this agenda on? So again, it's open, so, but I can start with maybe Gráinne, because you brought it up in your presentation.
Yeah, I think, well, at the lowest level, it's definitely in terms of the data linkage or the data analytics. It really needs, there needs to be strong biostatistician support.
Yeah.
So that really needs to be there, and it needs to be there, like supporting postdocs coming through, PhDs. And I think the real challenge, and I know talking to a lot of people who've recently been awarded grants that need biostatisticians, they're finding it really, really hard to get people.
Yeah.
So I think,
And that has come up in lots of different programs,
yeah.
you know.
I think even at the level of the data providers, I mean, often, excuse me, we underestimate the effort, if you like, in terms of collecting and providing data into, you know, trusted environments. So, you know, there's a huge job of work, I think, around the capacity building of those data providers, because sometimes they are frontline service workers who also have a role in providing the data.
Yeah.
So I think there's a job of work to be done there.
Yeah. Austin.
I just wonder in terms of scalability, because as you mentioned, I think one of the issues is critical mass of individuals with the expertise. All those individuals that you mentioned, you know, clearly, you know, there's industry pulls them in direction, and we want them to, you know, to do a certain job. There might be a role for university partnerships in this, because, you know, there's 6 or 7 universities here. They all have critical mass in terms of that. So perhaps a pooling of that resource might be proactive and again kind of hasten the timelines. Yeah, absolutely. I don't think we'll find them all in one centre, you know. So I think the academic institutions have an important role there.
Yeah, absolutely. And Francis, from your perspective, from the trusted research environment, is there particular new roles and new areas that we need to start thinking about?
Yeah. So 3 points on that. I think certainly within the HSC we had to be realistic that the type of skill sets that we want around data analytics, programmers, Python coders, we just don't have. We don't have a significant enough cohort of those people currently within HSC to deliver that role. They are attainable, but you're competing with industry. So the salaries and the contracting that you're offering need to be at least at a base level to compete with industry, to attract them in. Linking in with universities is one good way to do that. A lovely point that was made by Jess from Open Safely, actually, and if you're very interested in what cutting edge looks like and how to actually really do this, you should go to Open Safely and have a look at what they do. But basically, her term was that once the salaries are a hygiene point, you've got a base level salary that's competitive. The one thing that you do have that some people in the private sector don't have is vast amounts of data for programmers to play with.
Yeah.
And the one thing that they want is access to vast amounts of data that they can play with and then show off on their fabulous code that did something wonderful. So you can entice them with that, but unless you're going to pay them at appropriate salaries and give them a trajectory to work within and to value that knowledge. We also have to have a change in culture here where the people who currently own the data and created the data don't understand, with the greatest of respect, the capability of that data when it's placed in new technology environments. And we need to get to a space where people are comfortable and safe and moving to that. If that means Microsoft turning up with a big truck to suck out your data, fix it and hand it back to you, that's what that means. And we need to play better with industry to understand where there is specialty in this remit. But your data is your currency, that is your strongest asset.
Yeah.
I think, to be fair as well to data controllers, they're often collecting the data for a very different purpose.
Yeah,
and
completely.
they're busy and they're pulled in multiple directions, so
Absolutely.
often they're not doing it to be difficult. Yeah.
No, and on the point around data quality, data that's being collected for health service provisioning, the quality may be sufficient for that purpose, but not sufficient for research purposes. But we can challenge that again. Provisioning of data quality in one standalone data set is very different than placing 3 data sets which may not have great quality together and making a linked data set. That could have immensely more accurate data simply by linkage and the learning that we can get from that. So you can, just because 3 data sets have poor data quality, putting them together could immediately increase that data quality. So it's understanding that and respecting that data quality, which is high for service provision, is not necessarily high for research purposes.
Yeah. Great. And then just finally, I'll move on to one question before I open it to the floor. It's touching on the last points that you were making around citizen trust and transparency, and trusted partnerships has been sort of a mini theme throughout this as well. At the moment, from different surveys and citizen juries, the mood music is good in a sense that citizens are, open and interested in having their data accessible and used for research purposes. And I suppose the question as we move into this space is, how do we ensure that we maintain that and sustain that? And I think you were touching on your panel, but if there's other things that we need to be thinking of and making people aware of, so you stitch it in, and not to lose all of that goodwill at the moment.
Yeah.
Again, it's for kind of everybody on the floor if you want to.
Well, just to go back to the COVID pandemic, I'm not sure if anybody in Ireland was given out about people using their data on who were positive or negative, were tested or vaccinated. So that was almost a litmus test that get the data, show what it can do, tell us where the hotspots are. I didn't see anyone kind of giving out. I mean, I can't remember, far back, but I think that was a litmus test. And I think it will be similar, but I think, yes, we have to inform and educate the public. I think there's a body of work to be done in that space, and I think you've already kind of started the process.
Yeah, so around the social license views, COVID was a beautiful, easily understandable demonstrator that we can use with our public around what we can do with our data. But there's also the backlash of just because you did it for that doesn't mean you can use it all the time. But what we found in some of our, and they were small numbers, but in some cases the public's understanding of what they think you're already doing lots of things with their data that you're just not. And they think that their data is already linked and that we can all see different things and that we don't. So part of this solution to this is being honest and transparent about how bad patient data is, and be honest about it, and about what you need to do to improve it and the implications of that. That's a very difficult thing for people to do for a variety of different reasons, but we need to do that in approaches that are safe in terms of our service provision, but also to engage the public and how we can make this better. And also just being transparent. So in the case of TREs, data use registers, here's all the registry of how we use your data and what we use it for. Here's a registry of all the projects, here's who run the projects. So data inventories and case studies that are publicly consumable that people can understand. All of that goes a long, long, long way. Very simple slides that say, here are 5 safe things, do you know what this is? And not being afraid to bring our publics into the system and not wait for them to be patients who've had some type of terrible life course that has caused them to now sit on a panel and go, please, please, please do something. Can we not engage them before that happens?
Absolutely. We have 4 minutes left if I stick absolutely to time. So I'd like to open it up to the floor. If anybody does have a question, it'd be nice to hear from the floor at some stage today. Oh, we have one over here.
Just fantastic. Just on the TREs, I think, first of all, in Ireland, what we need is a cultural change. We need a TDE, a trusted data environment. You wouldn't believe, or maybe you would, just how bad the data that's entered into a system in Ireland by house officers who probably never saw the patient might mean well. The drugs are wrong, the diagnosis is wrong, and that's the system, and that's entered in these national databases. So in other countries, you get trained properly in data management and data entry and data quality, and those sort of structures don't exist in our hospitals, or which is where most of the data comes from. In GPs, it's a little different because they have ownership of their patients. But even then, the quality of the data is not what it should be, even for clinical purposes. In the VA 30 years ago, they went from all paper, which was just like we have here, to totally electronic within 2 years. And it's a similar population to the size of Ireland. They're scattered all over America, as far away as Hawaii, which is as far away as we are from Boston. Irish engineers did most of the work. We were offered 17 billion. We were offered that system, the Vista system here. The government said no. So, we really do need to move beyond just saying no all the time to yes, we can type attitude. But we really, when that sort of system comes in, like Epics, it doesn't really matter. If we don't have proper systems in place to train people about data quality going in, it really just becomes a garbage in, garbage out.
Yeah.
We've 28 electronic records just in our hospital alone, and a variety of paper records.
And it's diverse across primary and secondary care as well. And you're right, there are cultures around that. And in defence of everybody who is a data owner and data provider, you know, all of those provisions were put in place for best practice at that time. People thought that by segregating your records of data, you were keeping it safe by having them in different places. That's definitely a challenge. And with us rolling out Epic in Northern Ireland, you know, Epic's not going to solve it unless everybody understands that the rollout of Epic under Encompass is the responsibility of every single person in the HSC and every single person who engages with that system. So I take your point, and I think it's common. It's not unique to Ireland, certainly.
Okay. Yep. We have one more question here. Katrina.
Thanks. I'm glad I didn't have to try and catch that. I'd drop it. No, it was maybe just to tease that out a little bit, because I think you started to address this, the kind of the feedback, the virtuous feedback loop, because of people who are the healthcare providers who have to enter in the data, see the value of this coming back into the system. Yeah. That's where you're going to get a change that'll be long standing and will go beyond anyone who happened to get a nice, you know, training course on data entry, because it'll mean something for them. So I'm just wondering, given that you, just in relation to the TRE, given that the focus is research, I don't know, have you encountered anything in Northern Ireland in terms of that feedback loop into the clinical care and healthcare system, which would kind of incentivise that cultural change and how people see a benefit for the people that they're caring for?
Yeah, so outside of the trusted read, this is not my work, I'm not responsible for it, but the example that I would give would be under GPIP. So the GPIP project sought to bring all the GP data from a range of different providers into one GP platform. By doing that and by coding the data coming in from the different GP platforms, they've been able to provide GPs back dashboards of information on their patients. And then there's a dual purpose to the next step, which is looking at the quality outcome framework document, which is a list of different serious diseases and implications for patients, have those dashboards reported back to GPs. But then in the trusted research environment, my ask is, if you're looking at QoF coding right now, can I please have the QoF data into the trusted research environment? And then we can use it together and we can improve it, because that type of subset of data is a nice subset to bring into the trusted research environment to allow people to use QoF, quality outcome coding against prescribing data or against any of the data sets in the TRE. So that's one way that nice affinity has worked across, where there was a separate innovation in creating this GP platform to harmonise all the GP data from disparate systems into one, produce a dashboard back to GPs for their benefit. But by improving the quality of that data, then we go on, and can I have it too, please? And then we put it into the library, into the TRE registry, and then that subset of GP data can be used by researchers. We demonstrate that it's being used safely. We produce some outcomes from it. It gives confidence then back to the GP board to say, we're happy that data was used in that way, it was safe, and then we move on to another subset. So that's how you move these data pillars in to make a better library of information that people can commonly use.
Thank you so much. I think I'll call time at this stage, because there could be plenty more questions, but the panelists are around to socialise and can pick up on questions. So I'd like to just join me, please, in thanking all of our panelists for a very interesting discussion.